We are broadcasting live from Children's Hospital of Wisconsin. My name is Corey. I work on the social media team, and today I'm joined by Dr. Kurt Hecox and Dr. Sean Liu. They are the co-directors of our Epilepsy Center, and today we're going to be talking about the diagnosis and treatment of children with epilepsy, and we would love to hear from you. Dr. Hecox is a pediatric neurologist, and Dr. Liu is a pediatric neurosurgeon. So if you have questions for Dr. Hecox or Dr. Liu, or if you'd like to join our discussion about epilepsy, please go ahead and post your questions in the comments section of this video, and we'll try to answer as many as we can throughout our live broadcast. And thank you to everybody who posted their questions ahead of time. Now, if you like what you're hearing today, please go ahead and click the like button on Facebook and let us know. So to begin with, let's learn a little bit more about both of you. Dr. Hecox, can you describe what a pediatric neurologist does here at Children's Hospital of Wisconsin?
Yes, a pediatric neurologist is a physician who takes care of children who have neurological diseases. Those can include cerebral palsy, very rarely strokes, epilepsy, a broad range of neurological problems. Our discussion today is mostly about those children who suffer from epilepsy, and the role of the neurologist in that context is, as part of a team, to collect data, as much data as possible to understand what might be causing the seizures to happen, and to formulate a plan to try to minimize the consequences of the seizures and minimize the frequency of the seizures.
Okay. Dr. Liu, can you describe what a pediatric neurosurgeon does here?
Sure. So neurosurgery involves the surgical management of problems with the brain and spine. Mm-hmm. And a pediatric neurosurgeon is someone who takes care of those problems in children. And so here we have 3 pediatric neurosurgeons, and we just exclusively take care of kids. Mm-hmm. And then within that, epilepsy surgery is its own subspecialty. And so pediatric epilepsy surgery is a relatively small niche within the broader field of neurosurgery.
Okay, well, let's maybe take a step back and get a better understanding of what we mean by epilepsy. Could you help define epilepsy so we understand what that really means?
For many years, we thought we understood epilepsy, and we thought it was relatively easy to recognize it. It simply is a person who falls to the ground and is unconscious and shakes or gets stiff. Right. Epilepsy. The symptoms and the signs of epilepsy are extraordinarily diverse, but what's at the foundation of all of them is that there is some region of the brain whose electricity is misbehaving, not following the rules. Okay. Our nerve cells talk to each other by electricity. That's how they communicate, and communication is the primary function of the brain. So when that goes awry, one of the most common causes of it not functioning properly is epilepsy.
And so that means not always seizures, or there are always seizures? How do seizures present when epilepsy is occurring?
Yeah, seizures can present in the most dramatic fashion that we think about from television and other media, which is someone can have a jerking of an arm or a leg. They can lose consciousness. But also, one can simply have a few seconds of staring off into space. We all do this. That's associated with this abnormal electricity, and that too is a seizure, an absent seizure. We can have people who get confused about where they are. We have people who will walk around a house, and when they want to go to the bathroom, they'll open the coat closet, walk in, and be confused about how they got there. Mm-hmm. So there's just an enormous range of signs and symptoms, and that's what's changed the most in terms of our understanding of how frequently are seizures present in the population, etc. Because all of those subtle forms of seizures make up 3/4 of patients who have seizures.
Really? Now, are you always born with epilepsy, or can you get it later in life? I mean, how does it work when you're working with the child population versus the adult population?
It's more fun dealing with kids. But again, there are many different causes, some of which Dr. Liu will speak to in terms of brain injury from trauma, etc. Mm-hmm. But there are other things where a child is born and is unable to break down even food, the simple foods. Years ago, something called phenylketonuria was recognized actually here in the state of Wisconsin, and programs were put into place to screen all children, all newborn, for these things. And so that's one whole group where those children are born from day one. Other children may have an infection, and because of the infection, it injures the brain, and that has consequences in terms of seizures. But there are many other forms that...
Yeah, if you think about anything that injures your brain, injured brain can seize. So that can be trauma, it can be infection, it can be a stroke, it can be a number of processes. It can even be another brain surgery.
Wow.
It can be a tumor. Anything that's kind of irritating or upsetting the brain, has the capacity to cause seizures.
Okay, let's go to a question from our Facebook fans. Mike asked, when there's no known cause of why a child is having seizures, do you consult with the GI doctors to check on the health of the gut? Do you believe there is a gut/brain connection?
Well, we're brain people, right? And so we believe that the brain is all powerful and is connected to everything. There's actually a little bit of truth to that, not just bias. But yes, there are disorders that affect both the gut and the brain. If we're unable to absorb certain foods, then the brain doesn't get that nourishment, and if it doesn't get that nourishment, it will cause injury. So there are other chronic disorders of the gut. Do we typically ask for a consult from the GI people? No. There have to be signs or symptoms or some complaint on the part of the child to cue us into bringing our GI colleagues into the discussion.
Okay. Looks like we have a question from our live audience as well.
Allie would like to know, if kids are having obvious seizure-like tremors but nothing is getting picked up by the EEG, would you still consider that to be epilepsy?
Well, none of our tools are perfect. The EEG, which is a test for measuring electricity from electrodes on your scalp, in general will pick up 80 to 90% of seizures. But there are seizures which can occur deep in the brain, which are not visible to us with routine EEG. So yes, it is possible to miss them. So that's why we say the diagnosis of epilepsy comes from a combination of the history, the physical exam, seeing the seizures, the electricity. All of those must come together before we make a statement that the child has epilepsy.
Okay. And now the EEG is one of many different tools that might be used to detect that. Is that right? What are some of the other tools that are used?
So when we talk about EEG, we're talking about electrodes on the skin. And that's measuring electricity through skin and fat and skull and the covering over the brain, and trying to even get to the depths of the brain by measuring fairly indirectly. Okay. So one diagnostic that's invasive that we do sometimes is surgically implant electrodes so that they're inside the skull. And so it's a way of getting improved precision to what you're monitoring. The electrode contact points are more tightly packed. They can be right on the brain or inside the brain. And so it's a better way of getting more direct information about that electricity. Okay. Outside of EEG, there's imaging studies. So there are imaging studies. The primary one would be MRI, magnetic resonance imaging, that gives you good anatomic information about the brain. There are other types of imaging, functional MRI, perfusion MRI, SPECT, PET studies that will actually look at brain activity. That's at baseline and during a seizure. That might give us some indication about what part of the brain is involved with seizure onset. It's a long list. I don't think you want to go through this whole list, but there's a ton of diagnostics, and it's tailored towards the individual patient. Okay. But it's all geared towards answering the questions of whether they're appropriate for surgery, whether there's a surgically amenable target. Right. And so people that are good candidates for surgery are people where their seizures are all coming from one spot, one area of the brain, and hopefully that area of the brain is someplace that's safe to take out or disconnect. People that are not so great candidates are people who have seizures from multiple areas of the brain, or people where you can't figure out what part of the brain it's coming from with all of these tests. So there's a lot of variety in epilepsy. There's a lot of different types, a lot of different causes, and every patient gets their own tailored workup and decision-making algorithm based on their particular seizures.
Okay. We have a question here from Holly, who asked us earlier. My son is 14 years old and has been recently diagnosed with epilepsy. His EEG and MRI were normal, and he has been diagnosed with with anxiety disorder. Can high anxiety itself cause seizures?
It can.
Yeah.
It can. Any form of stress can cause seizures. High temperature, sleep deprivation, and sleep deprivation is probably one of the more common real causes among patients who are anxious. Patients who have high anxiety typically have a little more difficult time sleeping and getting regular sleep, and that's one of the key precipitants. Mm-hmm. It is not common, however. If we look at all the patients who have anxiety, only a very small percentage of them have epilepsy.
Okay. Looks like we have some more questions from our live audience as well.
Holly wants to know, can a child develop processing disorders from having epilepsy?
The answer to that is yes and no in the following sense, that if we look at all of our children who have epilepsy, about 1/4 of those children will have some delays, some challenges from a cognitive and school performance perspective. Of that group, there is yet a smaller group who have processing delays, who take a little bit longer to learn things, but nevertheless are capable of continuing to progress and do reasonably well in school. It really is not the seizure itself, though, that's causing the processing difficulty. Whatever causes the seizure, which is brain injury, is what's causing the processing difficulty.
Although, would you not add that uncontrolled seizures over time is its own source of damage?
Boy, that's such an important point, and that's part of why it is so important to bring seizures under control in a timely way. I think we learned that from adults who had 20, 30 years of seizures, and they have memory problems, etc. And we used to think this didn't happen in children, but it is absolutely the case that untreated seizures contribute to school performance problems.
And are there certain types of seizures that are dangerous? Like, is epilepsy itself a dangerous condition to have, or does it depend on other factors?
Wow. For most patients, epilepsy is not dangerous. Mm-hmm. We want to bring it under control really for two primary reasons. One is it's been very difficult for anyone to predict which patient will have a very long seizure, because it's long seizures about which we're most certain will cause injury to the brain. Mm-hmm. We don't want a child to have more injury in their brain. So we have to do everything possible to prevent long seizures and frequent seizures. An individual seizure itself is only infrequently the cause of injury or danger. There's something called SUDEP, sudden death, and it's a terrible, terrible thing, but it's a very small fraction of those patients who have uncontrolled seizures. So those really are the dangerous parts of epilepsy. For most patients with epilepsy, it is not a dangerous disorder.
Okay. I'd like to maybe transition to some of the treatment options that are available to families with children who have epilepsy. And I know we talked about surgery. Are there minimally invasive surgeries that are options for families?
Yeah, there are. They're not appropriate for everybody,
okay,
but there are. So on the diagnostic end, part of epilepsy surgery is diagnostic in that you're trying to figure out where seizures are coming from. So there's been a trend, over the last few years to implant electrodes into the brain in a less invasive way.
Okay.
So rather than doing a big opening in the skull and taking off all this bone and dramatic, incisions, we are moving towards doing more cases where we're making little incisions, implanting tiny wires that go into the skull, but that are much better tolerated by the patients, less discomfort, less scarring, etc. So that's on the diagnostic end. On the therapeutic end, most epilepsy surgery is about taking out brain or disconnecting brain. That's where the seizures are coming from. And there's two avenues where we're getting less invasive. So one is there's more use of smaller openings and endoscopic techniques to try to limit, the opening and the kind of the damage from the approach. And then the ultimate kind of minimally invasive tool that we have right now is what we call stereotactic laser ablation, where we implant a tiny catheter that's connected to a laser, and we can put it in a small target and deliver the energy from a laser in real time, monitored by MRI, to kind of destroy small areas of the brain. And
so when you talk about destroying small areas of the brain, that seems scary. I would imagine when you're talking to a parent about brain surgery, it's probably always anxious time. What are how do parents react when you talk about doing brain surgery, and what are some of the complications, some of the risks, I guess, with that?
Yeah, it's there's a bit of a prejudice against epilepsy surgery, and brain surgery in general, because people feel, rightly so in the past, that this is an extreme option, and this should be kind of a last ditch, like this is only when everything else has failed and you're painted in a corner. But it's really not like that anymore. And because the success rates have creeped up over time and the complications have come down, by an order of magnitude from the early days of epilepsy surgery, we feel that it should be considered earlier and more often than it probably is by most people. And so when you ask what those conversations with families are like, they often start out with the parents being fairly frightened by the prospect. But by the end of those conversations, I think most of them are somewhat surprised by how reasonable the whole thing sounds, and how it's not anything like what they thought it would be like. There are complications with everything that we do, and Dr. Hecox has heard me talk about complications hundreds of times now. But I think about it as major and minor stuff. And to me, major complications are things that make you permanently worse, never the same again. And minor are temporary fixable things. The vast majority of complications that we expose patients to with epilepsy surgery are of the minor kind. Yes, we can have problems, but yes, they are unlikely to change the big picture over time. Major complications, the complication rates are extremely low. They're on the order of 1%. Minor complications are more common, but they're minor in the sense that, if we have a 5-year-old patient and he develops a wound infection, when he's 18, he's going to look and feel and be the same kid or adult, whether or not he had a wound infection when he was 5 years old. In the short term, it can be a roller coaster, but in the long term, those kinds of complications really have limited impact on somebody's life.
It's sort of stunning what a bias issue and a fear issue there is out there. There was a very interesting comment made in the New England Journal of Medicine a few years ago, pointing out that if in the world of cancer someone developed an intervention that cured 60 to 70% of the patients who took that medication or intervention, people would be doing the happy dance. They'd be celebrating. They'd be saying, what a great breakthrough. And so it is a stunning statistic that of those children in the United States who can be cured of their epilepsy, less than 2% of them are offered that opportunity. And so it is, and it all comes back to education and all of the ideas we walk around with in our heads, and how we need to do a better job educating people about what is possible for their children, that their children can have better lives.
Yeah, it's amazing. Looks like we have some more questions from our live audience as well.
A few different people actually in our live audience have asked about the possibility of offering CBD oil as a treatment option.
Well,
first, can you describe what CBD oil is for those who don't know?
Yes.
Okay.
This is not a surgical option.
Okay.
This is, there is a substance called marijuana. Marijuana is a very complicated thing that contains over 50 or 40 different components, some of which are used for recreational purposes, and some of which are being investigated as treatments in cancer, in pain control, and now in epilepsy. Skipping sort of the controversial aspect of right or wrong, there is data to suggest now that there are indeed some patients who are effectively treated with a portion of the marijuana substance. And those patients so far have something called Dravet syndrome. So it's a very specific syndrome where we get this very specific benefit. Outside of that area, quite frankly, not enough data has been collected to say to a parent, yes, your child would benefit. No, your child wouldn't benefit. That's going to take time, and that's very frustrating, particularly for families that have searched long and hard for solutions. But if we want to do this safely and responsibly, what we have to do is do exactly that. There has to be responsible manufacturing. Right now, CBD oil is not under good manufacturing practice control. So I think I have 27 families who take CBD oil. And so we've been exposed to sort of what are the pros and cons and how do you manage that.
Right.
And it isn't easy. Because of the lack of manufacturing control, the supply that family gets one month is very different than it might be another month. And so there's a lot that we have to do to make this come into the mainstream of treatment. But I believe that there are patients who will be helped. Right now, it's not legal in Wisconsin for us to prescribe it, and we don't. We help those patients who are taking it from other sources remain safe and under good control. But we'll hear more from this story, but it will take time.
Okay. So what other types of medications are involved in the treatment of children with epilepsy?
That's a long string. The treatment of epilepsy began thousands of years ago. Ironically, the first treatment was simply to get rid of people, tell them they couldn't live in the village any longer, and tell them to leave, and they'd go out in the desert, they'd starve to death, or they would starve enough to stumble back into the village, and their epilepsy would be cured until they ate another meal. And so that was the beginning of the ketogenic diet. So there are dietary forms that can be very helpful to people, sort of starvation. And there are dozens of medicines that come from very diverse fields. These are medicines that have been used for movement disorders in the past, anxiety, or medicines that were developed specifically for epilepsy. But there are dozens of these medicines. And I don't think I'm going to subject you to a detailed discussion of their pharmacology,
Right.
At least at this point.
I have a question here from our Facebook fan, Lisa, who asked, what percentage of kids are able to be successfully weaned from their seizure medication? Also, if they wean off completely and begin to have seizures again, are kids able to go back on the medication that they were using and have them controlled again?
Well, the success rate for weaning depends on the type of epilepsy.
Okay.
So there's a form that people have heard of, petit mal epilepsy or absence epilepsy, where the successful weaning of a child occurs in about 80% of patients.
Okay.
So that's great. We all love that. There are other forms where the weaning process is unfortunately something called Lennox-Gastaut syndrome, for example, where the weaning process is successful less than 5% of the time. So there's an enormous range. And so answering that question really depends on what the underlying disorder is. What if you wean off and the problem comes back? Can you restore the child? Most of the time. There are children where once you lose that control, it is even more difficult to regain that control. We can't predict ahead of time who that child will be. However, we don't have a tool to do that.
I have another question here from Tanya, who asked, when kids go through puberty, is it possible that their shifting hormones will affect how well their medications work?
Yes.
Yeah.
A lot of things happen in puberty. Your seizure type can change. And if your seizure type changes, then the medication that's best for you changes. Interestingly enough, children who have had generalized seizures sometimes turn into focal seizures, and if they have focal seizures that aren't under control, that opens the door for a surgical intervention. So yes, there are major shifts that occur in that age group, and sometimes for the benefit of the patient.
Okay. Looks like we have some questions from our live audience as well.
Shannon would like to know, should a child with uncontrolled seizures with LGS be seen at a level 4 facility? Are there more options at a higher level epilepsy center?
So what are the different levels? What does that all mean?
So there's kind of a nationally accepted accreditation group that looks at the resources that every center has that does epilepsy or takes care of epilepsy, to try to give consumers and patients and other physicians a sense of, what's available, what's possible, etc. And so that goes from 1 to 4. And so a level 4 program, it's a pretty high hurdle to get over, and it requires really to have no significant gaps in your resources. So you need epilepsy surgeons, who have had special training for epilepsy surgery, pediatric or not pediatric specific, even. You need epileptologists. You need an epilepsy monitoring unit where you can video survey patients having epilepsy while they're hooked up to EEG and capture those seizures on video to help interpret that data. You need neuroradiology and all the different imaging modalities that are standardly used to evaluate that. You need neuropsychologists to evaluate patients for pre-existing and then deficits, or to assess a cognitive baseline and to be able to follow that patient over time to see how they're doing with their development, either with or without an intervention. That list goes on and on. You need physical therapists. You need but there is a certain kind of level of security you have with a level 4 center that that all the bases are covered at this place, and you're not going to be not offered a possible solution because they don't have it here, or that surgeon doesn't know that technique.
Right.
So he's only going to talk about the things that he knows because he never learned how to do this or that. So that's what you get from a level 4 center. It doesn't mean you can't get good care at at a level 3 center. It just means there's less assurance of that. There's something missing at those centers that didn't give them that grade, and what is it, and does it, and will it apply to your particular case? It's hard to know.
Okay. One of the barriers for families is fear of, if I live in central Iowa, why would I want to have a doctor in Milwaukee, Wisconsin? And it's really important to understand that sometimes it's a single visit, a single evaluation, just to let the family know what their choices are.
Okay. Now, we're talking about our space here. I just walked down the hall. We have a long-term epilepsy monitoring unit. Can you describe, what does that space do? What is it for?
Yeah, the epilepsy monitoring unit is exactly what its title implies. We put electrodes on the scalp or implanted in the brain of a child, and we collect information about the electricity and the electrical patterns going on in the child's brain. With that information, we can say, are there seizures or are there not seizures? How many seizures are there? Where are the seizures located in the brain? Are they in a sufficiently restricted area that we could possibly offer surgery? Are they coming from many areas, and therefore medications that are particularly developed to address multifocal epilepsies should be used? And at the same time, a lot of the nurses do a lot of education, a lot of counseling, and that also puts a child in a situation where if GI consultants are required, they can come. If an endocrinologist is required, they can come. Both the neurosurgery team and the neurology team have access to that patient. We do the imaging while the patient is here. All that goes on in a single location.
Yeah.
And potentially at a single time.
Cool. Really cool. We have a Facebook question from Beth who asked, are there any helpful supplements for children with epilepsy or generalized seizure disorders?
Yes. Some of the supplements have been studied and verified, and other supplements are less well understood. But that depends on the medicine. So, for example, there's an old medicine called Dilantin that's still a very powerful medicine. All patients on Dilantin for a long period of time should have supplements to help with their bone physiology that will protect their bones from having troubles that come from this particular medicine. Pyridoxine is now being used for one of the common anticonvulsants called Keppra because it helps with behavioral issues. So each of the anticonvulsants has sort of the potential of creating a vulnerability in the child, and some of those vulnerabilities are addressed by supplements.
Okay. I'm curious to know what your thoughts now as we kind of get towards the end of this live broadcast. What does the future look like for the care of children with epilepsy? When you look ahead, what do you see?
Yeah. I see good things. I see improvements. I see technology improvements. I see hopefully an increase in the number of persons who can take care of children with these at times tragic problems. But the biggest challenge goes back to what we talked about before, and that's education. Parents have to know, and pediatricians have to know what the choices are. Mm-hmm. They have to understand how much good can be done, and that that the future is hopeful. It's not dismal. It's not, oh, my child is forever going to suffer from this disorder. No, that does not have to be. And so I think doing more of what we can do today to reach beyond the 1 or 2% of people that we can cure is exciting. And that will come not from additional techniques and high technology, but persisting in the community of educating families, community leaders, pediatricians.
Okay. Dr. Liu, do you have any final thoughts when you reflect on this conversation? And
I would further what he said about the future. You know, I personally am hopeful that we'll see some quantum leap in technology. And you can never predict where those will come from. It may come from a genetic standpoint. It may come from some new medication. From the surgery standpoint, we are a little bit in the dark ages still, I think, for this, where most of our treatments involve removing or destroying a part of the brain where the seizures are coming from. And I like to think that at some point our specialty will look back on these as kind of the dark ages where we were so primitive that all we could do was take out so that it doesn't seize anymore. So there is some burgeoning technology where we are using stimulation rather than removal to try to affect how the brain works while retaining its function. And so that there's a lot of kinks that need to be worked out with that. But that's an example of a future technology that we're hopeful of down the road of kind of changing the way patients are managed.
Dr. Hecox, Dr. Liu, thank you so much for taking your time. I know your time is valuable. And if anybody would like to learn more about Children's Hospital of Wisconsin, Dr. Hecox, Dr. Liu, or our Epilepsy Center, just visit our website at chw.org. Thank you so much.